Hey guys, so I wanted to talk about transient synovitis versus septic hip, which is something that came up as a clinical conundrum that people face relatively often. It's also one of our most common M&M presentations due to the fact that transient synovitis is a great mimic, and septic hip can have a subtle but very indolent onset, so it can fool you. And it's why we have to take the child with limp very, very seriously. To frame our discussion, I wanted to give you a quick overview of one of the most important papers in pediatric emergency medicine. It's written by Dr. Meninda Kocher from Boston Children's Hospital, and it's entitled Differentiating Between Septic Arthritis and Transient Synovitis of the Hip in Children, an evidence-based clinical prediction algorithm, and it was first published in 1999, so a while ago now. And what's great about this paper is it's not complex, but it shows the power of gathering simple data and analyzing it well. So basically, the study retroactively reviewed the cases of children presenting to a tertiary kids hospital, which I'm assuming is Boston Children's, with irritable hip between 1979 and 1996. And surprisingly, they've only got 282 kids in that study for that length of time. But from that data, they performed a univariate analysis and multiple logistic regression analysis, which basically means they looked back at all of the different features of the kids who presented and tried to find the symptoms and signs and tests that differentiated the ones with transient synovitis from the ones with septic arthritis. And they did. And that's why this paper is super useful. So when that was all finished, they found 4 primary criteria that could predict the chance of septic arthritis in the patients that they analyzed. One was a history of fever greater than 38.5. The second was that the kids who were non-weight bearing. 3 was having an ESR of 40 or above. And 4 is having a white cell count more than 12. Okay. And from that, basically, if you had none of those predictors, you had a less than 0.2% chance of having septic arthritis. If you had one of them, you had a 3% chance. But if you had 2, so if you have fever and non-weight bearing, for example, without doing any bloods at all, then your predicted probability of septic arthritis becomes 40%. If you have 3, you're up at 93%. And if you have all 4 predictors, you're at 99.6% chance of having septic arthritis. Now, further studies have dropped that sensitivity a bit based on either a change in prevalence or decreased, I don't really know. But what they have found is that with repeated studies, this is still a very useful and handy way of differentiating kids with transient synovitis and septic arthritis, which still has decent sensitivity. And why is this criteria so good? Well, one is that it's unambiguous and clear. Secondly is that the percentage chance of you having septic arthritis is actually well distributed between those numbers. And certainly if you're scoring 0 or 1, as an emergency physician, pragmatically, you're going to have to work pretty hard for why you're justifying calling ortho at that point. But if you're scoring 2 or above, so a kid with fever and non-weight bearing, you're already at 40%. So you really don't have much of an excuse for not involving ortho, unless there's another obvious diagnosis that would explain the pathology better. And then thirdly, this has been repeated in other studies, and while the sensitivity hasn't been as high in more modern populations, the numbers still differentiate pretty well. So this criteria is incredibly important to know about, firstly because it will clinically help you. Septic arthritis starts out as this indolent gradual process, but for kids with a limp for more than 3 days, or with fever or failure to weight bear despite good analgesia, which I'd recommend Nurofen for its anti-inflammatory effect, doing bloods is really important and actually really diagnostically useful. The second thing to think about is that this paper has had such a profound impact on pediatric orthopedic culture. And if we start talking to ortho using the same language that they do, then we start building more trust. So if I can call the ortho reg and say that I have a kid with a limp with Kocher criteria of 3, including an ESR of 80, our relationship and their trust of me is going to be stronger from the start because we're speaking the same language. The last thing to note is that this paper involves ESR, and ESR remains an important part of our workup of septic hip. Now, this paper was actually written before CRP was used commonly, and Meninda Kocher has actually noted that CRP greater than 2 gives a similar sensitivity. But you can guarantee that because of this original paper, when you're talking to an orthopedic registrar concerned about a septic hip, one of their first questions is going to be, what's the ESR? And when we haven't done one, it makes us look sloppy. And guys, even when we try for an ESR, we actually do it pretty terribly. So getting these bloods done right in the right patient is actually really important, since the white cell count and the ESR take up 50% of our clinical prediction algorithm. Now, others might disagree with my next point, so feel free to consider them potentially controversial or more personal. But here are some personal practical tips when working up a septic hip. The first is that I rarely do ultrasound without bloods if I'm working up a kid with limp. And that's because ultrasound will only tell me there's fluid in the hip, but it won't tell me if it's pus or reactive fluid in transient synovitis. The ultrasound tells me where the problem is. It doesn't tell me what it is. So if I'm doing an ultrasound, I'm usually going to do bloods as well. Secondly is that ESR stands for erythrocyte sedimentation rate. And that rate is over an hour. So it is going to take you at least an hour for that test to be done after it hits the lab and gets registered. So if you're working someone up for a septic hip that you genuinely are concerned they might have a septic hip, then you need to do your bloods as early as possible in the piece so that you can be fully informed when you ring ortho with the full data set that they need to help you work out where they need to see this patient. And there's nothing more inefficient than waiting 4 hours for an ultrasound report and then waiting 2 more hours for an ESR and FBC. So my usual approach is going to be, I'm either going to do nothing if I think this kid has transient synovitis and I have a safe management plan, but if I have legit clinical concern, I'm going to do ultrasound and bloods, and I'm going to try and get the bloods off early because that ESR is often actually the rate limiting step in calling ortho. Sampling wise is my third point, is that ESR is frequently rejected even when we do take it. So whenever possible, I'd recommend taking 2 EDTA tubes, one pediatric one for the FBC, and one adult one ideally for the ESR, or a really full pediatric one. You don't have to fill the adult EDTA, but if you put 1 or 2 mils in it, sometimes that can be easier for the lab to process. The EDTAs also frequently clot, just like FBCs do, due to difficult access and challenges with sampling. And so particularly for FBCs and EDTAs, sometimes I'd say practically it's actually easier if you've cannulated a child to just let the blood flow directly into the tube rather than trying to aspirate it with a needle. And the reason for that is that then it just drips straight in and it doesn't froth up like you get when you're aspirating a tiny vein in a kid's hand. And then as soon as you've taken that blood, you make sure either yourself or the nurse who's assisting you with that immediately closes the tube and then inverts it multiple times to make sure that the anticoagulant that's in the EDTA tube mixes with the blood and stops it clotting. Because there's nothing more annoying than 2 hours later realizing that you don't have the tests that you need. So those are my thoughts on septic hip. And I think this is a really important paper. Kocher Criteria is one that we should all know in pediatric emergency. It's extremely important, and if there was one paper I think you should read, I reckon it would actually be possibly this. Cheers.